Okay, thank you very much. The talk I'm going to give here is on fluid therapy in acute kidney injury. So we're all aware of the harm that we may cause by fluid therapy in this context, and more generally. This is a picture showing pulmonary edema on chest x-ray, and the dangers of volume overload are becoming increasingly recognised. This is a slide by John Prowl and colleagues. So I think we're cognizant of the risks of pulmonary edema in fluid therapy, but in addition, increasing recognition of the dangers of cerebral edema, myocardial edema, hepatic congestion, gut edema, which may lead to malabsorption and ileus, tissue edema, which can impair mobilization, wound healing, etc. And interestingly, increasing recognition that volume overload might actually be harmful to kidney function. So we may have reduced renal blood flow due to increased interstitial pressure and capsular tension, but also renal venous congestion may impair kidney function as well. So I think that while we want to appropriately resuscitate patients, we do see quite a lot of iatrogenic harm due to over-resuscitation in acute kidney injury. So how do we get the balance right? Often a decision on fluids will be one of the first ones we make when we approach a patient with acute kidney injury. Many of you will recognise these types of scenarios. You're on medical rounds reviewing a 6-year-old male with presumed pneumonia. You note from recent blood tests creatinine has risen from 100 to 180 over 48 hours. He has become increasingly breathless over the last 24 hours. So you know as soon as you've gathered that information, you're going to be making a fluid assessment and making a decision on whether or not this patient should have fluid therapy or whether they need treatment measures to offload their extracellular fluid volume. The second case, you're providing surgical ward cover. You're called to see a patient following major abdominal surgery. Blood pressure has been low and urine volumes have been tailing off 20, 25, 10, 20, etc. over the last 6 hours. So again, you're going to be thinking as you approach that patient, I'm going to have to make a decision about whether to give fluids and in what quantity and what type of fluids indeed. Okay, so if we take oliguric AKI, we will usually have to make some form of volume assessment. We can say a patient, we hope, is either hypervolemic, euvolemic or hypervolemic. If they're euvolemic, then they are managed in accordance with our thinking on euvolemic oliguric AKI. They have maintenance fluids. If they are hypervolemic, clearly they need a volume trial. If they're hypervolemic, we may need to institute medical therapy such as diuretics or renal support to offload extracellular fluid volume. Once we've established our patient as euvolemic, they will then either recover or need an ongoing oliguric maintenance regimen. So that's a broad overview of our approach to these patients. In this talk, I'm going to talk specifically about pathological oliguria, the volume assessment, how we might do a volume trial, medical therapy of hypervolemia, and the oliguric maintenance regimen. So oliguric AKI, this is a schematic of nephron function. We have a blood flow, afferent and efferent arterioles. We have glomerular hydrostatic pressure. We have a glomerular filtrate. The filtrate is added to by tubular secretion, but more importantly, huge amounts of tubular reabsorption. And this results in a very carefully composed volume and composition of urine, which defines our extracellular fluid volume and composition in turn. So we do see physiological oliguria. A fall in urine volume is a physiological response to circulatory insult. And we switch off GFR, this is sympathetically driven, and we activate the renin-angiotensin system and vasopressin axes. This for the renin-angiotensin system results in reclamation of salt and water in the distal nephron, the vasopressin axis water. And this will happen due to circulatory insult, but also due to other drivers such as surgery, and stress and pain may stimulate vasopressin release. So we do see transient physiological oliguria. What about pathological mechanisms of oliguria? Well, this is sustained decreased renal perfusion. We may see intrarenal vasoconstriction. We can see this in hepatorenal syndrome. We may have decreased filtration pressure. There may be a bona fide glomerular injury, such as we see in glomerulonephritis. We may have a tubular injury due to ischemia, sepsis, or drug toxicity. We may have tubulointerstitial inflammation, interstitial nephritis, and finally, we may have pathological oliguria due to obstruction. Profound oliguria, i.e. anuria, would most commonly be caused by complete obstruction, vascular occlusion, or a very severe, rapidly progressive glomerulonephritis that we see in Goodpasture's syndrome. So what does this mean for the patient? Well, it means that there's something that we need to fix to restore kidney function. But it's worth bearing in mind in pathological oliguria, the extraordinarily powerful and precise machinery of renal fluid regulation is lost. Fluid balance has been surrendered to the medical team. Okay, so we've got these extraordinarily precise, hard-working mechanisms determining our extracellular fluid volume and composition. That's all been lost. We've surrendered it to the medical team who have got to administer therapy, prescribe therapy, and this is often a hazardous proposition. So the volume assessment. So this is Shan Finley's work with the Royal Colleges. They did an evidence review to build a competency framework for acute kidney injury volume assessment, and these are the things they pulled out. So clearly absolute vital signs, but also relative vital signs. If someone's baseline blood pressure is 160/90, 120/80 may be very significant. Postural changes in vital signs are suggestive of hypervolemia, jugular venous pressure, capillary refill time, skin turgor, mucous membranes, and axillae give us an insight into interstitial and intracellular fluid states. We may see peripheral or pulmonary edema. There are the historical details. Has the patient had a lot of fluids? Have they lost a lot of fluids from diarrhea or vomiting? What drugs have been given? Have they been exposed to diuretics? Fluid charts, weights. Weights are a very good way to assess changes in salt and water composition in ECF volume from day to day. The response to passive leg raising, a volume challenge without administering IV fluid. A response to a direct fluid challenge. A response to a direct fluid challenge. CVP, static measurement or dynamic measurement in response to a fluid challenge, and biochemical values such as lactate and venous oxygen saturation. So these are all useful, of course, and it's what we have available and what we are competent at deploying. This is what NICE reviewed and recommended from the 2013 fluid therapy guideline. So they suggested hypervolemia may be present with systolic blood pressure of less than 100, heart rate of more than 90, capillary refill of more than 2 seconds, a respiratory rate of more than 20, or a national early warning score of more than 5. So I think sometimes this is easy. We approach a patient and this is fairly clear cut, and that's probably the majority of the time. So if we have a patient with acute kidney injury, we approach the bedside and do a volume assessment. If they have relative hypertension, tachycardia, a low JVP, increased capillary refill time, no edema, a dry chest on auscultation, and a history of diarrhea, we can say quite comfortably fluid is going to be a free hit here. It's very likely this patient needs fluid resuscitation, but in addition, it's very unlikely you're going to cause harm in this patient by giving them intravenous fluids. If we look at the opposite end of the spectrum, here we have a patient with relative hypertension, edema with a normal albumin, bibasal crackles, a positive fluid chart, recent IV fluid administration, and a documented weight gain. So we can say here with some certainty from all this information, it's very unlikely this patient will benefit from further fluid therapy or resuscitation. It's highly likely this AKI patient needs some form of offloading. Sometimes, of course, it is more challenging. We may have unknown baseline physiological values. We may have a low serum albumin, which might result in non-hydrostatic edema. We may have venous insufficiency, which results in edema. We may have acute lung injury, pulmonary edema that is not related to cardiac failure or volume overload, or we may indeed have poor cardiac autonomic function. So it confuses orthostatic and absolute values and responses to fluid challenges. This was a study that was published in JAMA looking at healthy volunteers, and they looked at postural pulse increment, postural hypotension, supine tachycardia and supine hypotension. With large amounts of blood loss, these healthy volunteers were exsanguinated, 630 to over a litre of blood. Postural pulse increment had high sensitivity and specificity. So one would say from this that postural pulse increment is the best bedside hemodynamic test for significant hypovolemia. It's worth bearing in mind, however, these patients were all healthy volunteers with good autonomic function, and some of these findings may not be transferable to all of our hospitalised patients. What about technology? I'm not going to get into this in any detail. I've cited a couple of good publications on the right here, but straight leg raise and aortic Doppler, pulse pressure variation, thermodilution and pulse contour analysis, esophageal Doppler, caval ultrasound and echocardiography have all been used to volume assess static measurements or response to fluid challenges. What about central venous pressure monitoring? Well, this was a study published in Chest, where a meta-analysis of 24 studies looking at CVP measurement in over 800 patients was performed, and the gold standard here were more invasive forms of blood volume measurement and volume responsiveness, and the authors showed a poor relationship between CVP and both absolute blood volume or volume responsive in resuscitation scenarios, and they concluded in this critical care group that CVP should not be used to make clinical decisions on fluid management. So what would I do? What do I do in my clinical practice? Well, I'd assess all the available clinical data. So what do I do in my clinical practice? What would I recommend you do? Well, I'd assess all the available clinical data, the historical details, comorbidities, fluid charts, weights, observations, and these may be absolute or relative to baseline, physiological challenge with fluids, lactate, and venous oxygen saturation. And clearly the response to the fluid challenge is part of the assessment. If they get better, you're on the right track. So moving on, what about the volume trial? So in the volume trial, this is an AKI patient where we've decided they may benefit from fluid resuscitation. So here we would recommend bolus fluid and reassess conventional parameters. Some controversies exist in the choice and clinical targets and choice of fluids. I think we need to bear in mind that we're not just trying to help the patient's kidneys, but their overall outcomes and the function of all organ systems. And in some cases, we may be resuscitating beyond restoring circulating ECF volume if we establish that an increase in cardiac output may be desirable and cardiac output is likely or is being increased by volume resuscitation. We can go to supranormal values. Goal-directed therapy targets more measured values such as cardiac index, calculated peripheral oxygen delivery. Is usually part of a bundle of care including inotropic support. So this is a conceptual model of acute kidney injury and fluid therapy by Himmel, Farber et al. Here we can see we have kidney function, and if we look at the bottom bit of this graphic, we have kidney function which is declining as mortality is increasing. We have a high-risk patient who becomes an AKI patient, and here we have a closing therapeutic window when they are volume responsive, going from hypervolemic to euvolemic. Eventually they have volume unresponsive AKI. At this point they have kidney damage and biomarkers are increasing, biomarkers of kidney damage. What fluids are commonly used? Well, in the UK, normal saline, high sodium and chloride concentration, supraphysiological, somewhat acidic, it's not buffered, so there's a pH of 5. Hartmann's solution, more physiological, buffered with lactate, pH 6.5, and finally gelifusin. Again, supraphysiological values for sodium, quite effectively buffered with a pH of 7.1. This was the SAFE study comparing albumin versus saline in resuscitation, no benefit in probability of survival shown. 4% human albumin solution, far more expensive than normal saline and should not be used in this context. What about hydroxyethyl starch? Well, there was an evidence review of this by the Giftasup group and also more recently in NICE, the NICE 2013 fluid guideline. Based on current evidence, high molecular weight hydroxyethyl starch should be avoided in patients with severe sepsis due to an increased risk of AKI. And they cited these two very high profile publications. Hess versus normal saline. This is Myberg et al. Who published in the New England Journal more recently. 7,000 well-matched critical care patients randomised to Hess or normal saline for fluid resuscitation. And we can see here no difference in probability of survival, but an increased instance of AKI in the Hess group, shown here in the upper slide. What about chloride liberal, such as normal saline versus chloride restrictive intravenous fluid, Hartmann's, Ringer's lactate, in critically ill patients? Well, this was a crossover observational study published by Bellomo and other authors in JAMA, and this showed that administration of chloride-rich fluids was associated with more acute kidney injury across all severity grades than the intervention group who had chloride-restricted fluids. What about goal-directed therapy? So John Prowl and others published a meta-analysis of 24 randomised studies. There was no difference in the overall amounts of fluid administered between AKI and non-AKI groups. And AKI reduction was only really seen when goal-directed therapy was deployed as a bundle of care that included inotropic support. So to summarise the volume trial aspect, I'd say if volume is unlikely to be harmful, try a volume challenge and reassess with available physiological and biochemical data. If there's no response or it's felt to be hazardous to give a bolus of fluid, escalate care for monitoring or flow-based hemodynamics. We would recommend separating out the volume trial, the resuscitation component, from maintenance. The latter is assessed from sensible and insensible losses and should be customised. What about medical therapy in hypervolemic AKI? Well, this is along conventional lines. We'd recommend strict fluid restriction, higher dose loop diuretics. The dose response curve has been moved to the right, so we'd recommend starting with 80 milligrams IV bolus furosemide. One can use 10 milligrams per hour as a continuous infusion. It's important not just to max out on loop diuretics, but to consider other diuretics such as thiazides and potassium allowing amiloride blockade. We can reduce the preload with intravenous nitrates such as GTN and opiates, which can be a useful calming agent. Supportive therapy with CPAP, and unless we're anticipating an immediate recovery of kidney function, escalation to critical care or renal unit support and renal replacement therapy. Finally, moving on to the oliguric maintenance regimen, some good guidance here in Giftasup. If we move to recommendation 27, in patients with AKI, fluid balance must be closely observed and fluid overload avoided. In patients who show signs of refractory fluid overload, renal replacement therapy should be considered. growing evidence of the harm of volume overload, which I started with. This from critical care medicine. So here we can see the cumulative weight gains in non-survivors. This is fluid balance positivity sequentially. Non-survivors, this group had a greater fluid weight gain. So oliguric maintenance regimen, if we're trying to hold the fort and avoid hypervolemic complications, if we're anticipating recovery. Otherwise, it's really just a holding measure until we start dialysis or continuous renal replacement treatment. So we'd give insensible losses, e.g. 500 mL orally, and tailor according to electrolytes. Consider bicarbonate of acidosis. If sensible losses are high, drain outputs, etc., we should replace those. Daily weights, strict fluid charts. You can remove the urinary catheter if they're oliguric. Restricted oral fluid is often adequate. We can use volume-reduced feeds. We can see undesired weight gains with drugs and nutrition, and if nutritional adequacy and therapeutics require a level of fluid administration that the patient cannot tolerate, we would need to institute renal support with dialysis or CRRT. It's a very nice, clear algorithm from the NICE Fluids guideline, which I'd recommend reference to, breaking down into assessment, resuscitation, maintenance and replacement approaches. So that's an overview of fluid therapy in acute kidney injury. I think it's salutary to note this is a slide from Bywaters and Beale in 1943, showing the detail and rigour with which fluid therapy was being documented against very precisely measured physiological and urine volume variables. So we could do it with this degree of rigour in the early 1940s. We should have high standards now. So I'd like to summarise. I'd say fluid therapy and AKI, we should use our best assessment of volume status using all readily available data. AKI may be volume responsive or unresponsive. Bolus fluids should be followed by reassessment. Balanced crystalloids are probably the preferred solution, and we would say avoid HES in severe sepsis. We should separate out bolus from maintenance fluids. Maintenance fluids are targeted at sensible and insensible losses. Before we administer fluid, we should say what is the potential for harm in each case, and that will depend on the volume of fluid we're planning on giving, the ward setting, degree of supervision, and the likely tolerance of the patient. An oliguric maintenance regime, assuming euvolemia, this is a patient who's been resuscitated, this requires a serious fluid restriction and is a bridge to rapid recovery or renal support. Fluid therapy should be customised, and oral treatment will often suffice. We've got some other guidance on londonaki.net, as well as more general educational materials also on our mobile app. And I'd like to stop there. Thank you very much for your attention.